हॅलो हॅलो
हॅलो.
हां स्टार्ट केलं आहे.
येस स्टार्ट केलेला आहे बघा ना. अरे माझा फोन कुठे ठेवला मी?
आवाज येत. हॅलो, आता येतोय आवाज?
I, Dr. Sriram Doshi, Secretary GPA Pune, welcome you all for today's lecture. It is given by well-known ENT surgeon Dr. Pramod Diwan sir. He had very good hand and a lot of teaching experience. Now I request GPA President Dr. Rupa Agarwal to say a few words.
Good afternoon, friends. We, like every Tuesday study circle, this Tuesday we have one of the very commonly seen problems and in our clinic, in our OPD practice, and we are going to learn about its differential diagnosis and how to manage those cases simply on OPD basis, and for which we have a very renowned, very well-known teacher, Dr. Pramod Diwan sir, with us to introduce Dr. Diwan. We also have our Joint Secretary, Dr. Sunil Bhujbal sir, with us. So without any further delay, I will request Dr. Bhujbal sir to introduce Diwan sir.
हेलो हेलो मैं हेलो हेलो
To introduce Dr. Pramod Diwan sir. When I was
Video on करा मतलब. Video. हाँ ठीक. Yes.
when I
Hello. 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 Can I start? But I can't get your voice. I can't get your audio. Hello. Ah, can you hear me?
Hello, sir.
Ah,
Yes, sir.
now I can hear. Hello. Hello.
Hello.
Now I can hear you.
Divan, sir, you can start, sir.
I can start now. Am I audible to you?
Yes, sir.
Am I audible to you, Siddharth?
Yes, sir.
Can I start?
Yeah.
Now I will screen the slides. No. Okay. Good evening, everybody. First of all, I'm very much thankful to all the DIAS members and the dignitaries, those who are present in front of me. I'm thankful to General Practitioners Association, Pune, for inviting me for this webinar and to give some of my experiences to share with you. Basically, I am also one of you. I am also facing the problems in my ENT practice. And I am commonly seeing the patients, those who goes to first to GP and then come to consultant. First patient goes to their family physician, they take opinion from them, and many of the patients, we can handle their problem at the OPD level. So that's why Dr. Joshi has given me the topic that common ENT problems which comes in ENT practice. You can see 20 or 25% of your practice is containing ENT problems. Ear problems, nose problems, that is rhinitis or polyp or sinusitis, just like that, or throat problems like pharyngitis, tonsillitis, etc. But all these patients did not refer to ENT surgeon for simple reasons. You can treat 90% of this patient at your OPD level. Only 10 to 15% patients you can refer to the ENT consultant, those who need surgery for ENT. But in my observation, many patients in general practice are having ENT problems. The ENT problems are very broad problems, or in a manner they can present in a place where vital organs are situated. If there is any nose problem, patient immediately having respiratory embarrassment or lack of respiration. If there is any ear problem, patient immediately having hearing problem. If there is throat problem, patient develops dysphagia and immediately he gives complaint and he can say that I am not feeling well. And at that time, patient comes to general practitioner or family physician first to tell the symptoms. So now we can start with some problems which can come in our general practice and OPD level, which are very common. I have selected very common problems which can be tackled in OPD level. So if you see here, the common problems, that is otalgia, otorrhea, deafness, Otomycosis, and FB or wax. Otalgia is pain in ear. Any type of pain in ear is otalgia. Patient comes with severe pain or milder pain or referred pain. We are going to see details of otalgia in next slides. Otorrhea, discharge from ear. Deafness, patient is having impaired hearing. Otomycosis, patient is having fungal infection in the ear. And many cases of foreign body in ear or wax comes for the consultation of general practitioner. In case of nose, the common problems are rhinitis, deviated nasal septum, epistaxis, that is bleeding from nose, furunculosis, that is small abscess in the ear, small abscess in the nose or hair root abscesses, sinusitis, nasal polyps, growths, and FB nose. The patient comes to doctor for the complaint of nasal discharge and fever in rhinitis, nasal obstruction in deviated nasal septum, bleeding from the nose in case of epistaxis, pain and swelling in furunculosis, headache in sinusitis, obstruction in nasal polyps or growths, and foreign body comes with history of insertion of foreign body in pediatric age. In case of throat, common problems comes to general practitioners level or family physician level. These are dysphagia, difficulty in swallowing, tonsillitis, inflammation of tonsils, either it is acute or chronic, pharyngitis, then hoarseness of voice. Change of voice is called as hoarseness of voice. So patient says, I am having change in my voice since last 10 days, 15 days, 1 month, or something like that. Laryngitis, it also includes change in voice with inflammation of larynx and foreign body, just like fishbone. Fishbone is commonest foreign body in the throat. Then coin, swallowing of coin, then peanut or something like that. So these are the common problems which come across the general practitioner, and they can tackle it up to certain 90% level in their OPDs. So otalgia, first we have seen पेशेंट आता है बहुत कंप्लेंट करता है कि सीवियर पेन इन द ईयर. The causes are external ear or middle ear that we have to define, and we can see the abscess in ear, furunculosis, impacted wax, foreign body, just like ball bearing or pepper or rubber. Small people always do like this. They put foreign body in the ear and they complain otalgia after 2 days. One thing I have to mention here about foreign body, you can see many patients of foreign body in your OPD. Patients relative come hurriedly in your OPD with rush and they say there is she has or he has inserted something in the ear or nose. See, whenever there is itching in the external auditory canal, at that time only foreign body is inserted. Whenever there is itching around the nose, in case of rhinitis in pediatric age group, there is insertion of foreign. No patient, no adult patient ever we have seen purposely inserting the foreign body in nose and ear. You can see if an adult person is sleeping and if small mosquito goes inside, then that foreign body is acceptable in adult age. But rubber, pins, then chalks, pencils, all these plastic, all these foreign bodies inserted in the nose or ear in the age group of 3 to 5 is purposely inserted by that pediatric patient because of itching of ear or nose. So that we have to calculate first why he has done that thing, and we have to start antibiotic or decongestant with that. Removal of FB is another part. That procedure is different. We have to remove it as far as we are possible in our setup or in our. One thing I have to mention that ear foreign bodies are that way simpler to remove. But nasal foreign bodies are a bit difficult to remove. Why it is so? Because foreign body in ear can go in the middle ear by perforating the tympanic membrane while removing. And we can afterwards we can remove it under general anesthesia. But foreign body in nose, if goes backwards while removing, then it is very dangerous. Because the pathway of respiratory system is directly crossing to the digestive system. So that's why that foreign body may dislodge in the trachea. So posterior foreign bodies never remove it in OPD. Anterior foreign bodies, anterior side of the nose, you have already removed it many, no doubt about it. But those are bit safe. But if foreign body in nose is posterior, at that time we have to take very much precaution. So this is about foreign body in ear, nose. So now this subject was taken from foreign body can cause otalgia, then perichondritis. Perichondritis is external ear or pinal infection, otomycosis, and traumatic injury over the ear. Then middle ear, acute otitis media, acute mastitis, and malignancy. The otalgia via fifth nerve lesions at teeth, jaws, and nasopharynx. Via ninth and tenth nerve, glossopharyngeal vagus nerve, lesions at oropharynx, laryngopharynx, and via seventh nerve, herpes zoster, facial. We can see if patient is having facial herpes zoster in the pathway of seventh nerve, that is facial nerve. Patient is having severe otalgia in that. Just like that, if patients come to you with discharge from the ear, that is called as otorrhea. So always consider external. There are three types of pathologies in otorrhea. One is external ear pathology, second is middle ear pathology, and third is causes outside the ear. These pathologies also can cause the discharge. So this slide is just to recollecting your this thing about anatomy of the ear: external auditory canal, tympanic membrane, middle ear, then cochlea, then nerve, auditory nerve, then eustachian tube, which is opening in the then parotid gland, then cochlear semicircular cochlea, semicircular canal, middle ear bony chain, that is Malleus incus stapes, which is fitted on the oval window. And after completing the circles of the cochlea, it opens in the middle ear. Once again, it is called as round window. So the external auditory canal, where we can get many diseases in the case of ear. So otorrhea, external ear pathology, there may be furunculosis, there may be otitis externa, wax with secondary infection, malignancy, and otomycosis, that is fungal infection, which gives very bad smell. Middle ear pathology, acute otitis media, CSO, cholesterol. This can. If you are having any patient of otorrhea, first go with X-ray, mastoid, both mastoid, Schuller's view. That can give you idea whether the bony erosion is there or what, whether cholesterol is there or what, or whether there any mastitis is present. The other causes of otorrhea, CSF otorrhea. If there is basal skull fracture or skull fracture due to severe trauma or head injury, at that time CSF leaks and it comes in the middle ear from the internal ear. Just the fractures of mastoid bone, just above the mastoid, we can get durameter. So CSF comes, CSF gets leaked from that place, and we can have CSF otorrhea. What is the difference between CSF otorrhea and routine otorrhea? The CSF otorrhea is continuous, number one. Number two, CSF otorrhea, there is history of trauma. Number three, there is history of long duration cholestoma or eroding disease. And CSF otorrhea is having history of continuous discharge, slow discharge from the ear, which is crystal clear. We have to send this discharge for the pathological evaluation, and we can get the idea of it. So CSF otorrhea is rare entity, but we can get some cases in post-accidental cases, those who are recovered and discharged from the hospital, and still patient is complaining of there is leak from ear. After 4 months, 5 months, 6 months, patient also can complain that CSF otorrhea. At the time of admission, if patient is not having any problem with ear discharge, but post admission, patient can tell general practitioner that my accident things are over, now I am fine, no problem. But one small thing is there, after 2 minutes or after 5 minutes, there is drop of watery discharge from my ear. I am absolutely symptomless, but this is problem. So at that time, if you see the city of skull or you repeat the city of skull, at that time, CSA prime otorrhea, you can see. Then parotid abscess. Parotid abscess can burst in external auditory canal from the upper surface of parotid gland. So it can be misguided as external otitis. The differential diagnosis, parotid abscess, there is history of parotid, infection, unilateral or bilateral, and patient is complaining of severe pain on the cheek and external auditory canal. The TM joint abscess is also having same thing, there is inflammation. So this is the previous oldest method of checking the ear, that is Bull's lamp, and the doctor is checking with head mirror. But nowadays have changed. Now we are having in our OPDs, in general practitioners OPD, we are having halogen lamp, and the we are having light source with it, and we can put direct beam in the ear canal, external auditory canal. So as far as possible, every general practitioner should have one otoscope, set of otoscope, one set of tuning forks for to determine the hearing, and number three, the halogen lamp with light source, and that can make doctor or examiner comfortable for examining the ENT patient. So this is my suggestion. All may be having already this thing, but those who are not having, we can arrange this, and we can see many more patients and many more diagnoses with these only three things. Number one is halogen lamp, head mirror, headlight. Number two, tuning fork test, and number three is otoscope, which we can see in the extraordinary canal. The type of otorrhea, we can ask the patient, what is the amount of otorrhea? We can ask the patient, what is the duration of the patient? If he says it is profuse and duration it is continuous, then we are having different diagnosis of discharge from the ear that is due to mastitis. Then type of otorrhea, whether it is serous means watery, serous means somewhat whitish water which is coming from the ear, serous fluid, like serous fluid. Then mucoid with pus, purulent with yellow-green pus. Then foul smelling, whether it is having smell, bad smell or what, and watery discharge. So whenever patient complains of discharge from the ear, we have to ask these questions, that what type of discharge you are. So it is having significant for every this type of discharge. If patient is having serous discharge, patient is having early infection. If patient is having mucoid, the patient can have blue ear. If patient is having purulent discharge, there may be mastitis or cholestoma. If patient is having foul smelling, there is eroding disease. And if patient is having watery, then there are chances of CSA otorrhea. The investigations, otoscopy, we have to do. Bacteriological examination, all of you are doing examination like culture and sensitivity. Whenever patient is not responding to 2 or 3 antibiotic changes, at that time, you have to think that bacteriological examination is important, and directly send that patient to pathologist to get done culture and sensitivity test. This is very, very important at the level of general practitioner or family physicians practice This is very important. Don't send patient to ENT consultant directly. You have to do the diagnosis pakka. You have to come to the conclusion, and then you can send that patient to further consultation if he requires. But bacteriological examination you must do at your OPD level. So whenever you are sending the patient to pathologist and asking him to get done culture and sensitivity of ear discharge, at that time you can get what are the resistant and what are the sensitive antibiotics for that particular pus. Then radiological examination, we have to do number one, X-ray mastoid, that is Schuller's view, then CT scan, then MRI. We can do according to the disease. Sometimes there are ear polyps, so we have to do biopsy at our own OPD levels. Just put 4% drops in the ear, wait for 10 minutes, and after 10 minutes, with punch biopsy faucet, we can take biopsy and send to the pathologist. Then routine investigations like hemogram, BSL, urine, BTCT, just like we have to do in case of this. So treatment is specific. Treat the cause. If there is mastocytitis, treat mastocytitis. If there is cholestoma, remove the cholestoma with surgical procedure. You can refer the patient to the ENT surgeon for removal of cholestoma, and requesting the surgeon that further treatment will be done by general practitioner or by me. And if you are having any follow-ups, we can see the patient, we can treat the patient at our OPD level. The general ear drops, antibiotics, and cleaning of the ear is very important. It is called as toileting of the ear. Then next is deafness. Deafness is impaired hearing and types. बहुत खूब सार, बहुत सारे लोग आते हैं और कहते हैं कि नाउ डेज आई एम गेटिंग लेस hearing. So hearing के types, as you know all, three, that is conductive deafness, sensory neural deafness, mixed deafness. Conductive deafness is found in case of all age group, starting from 20. Whenever there is conduction of wavelengths of the sound, and it is not going and up to the auditory nerve to the brain center, at that time conductive loss deafness is there. Sensory neural loss, perception or the sensation by neurons, it is not doing correct job, and that's why deafness is present, which is starting from foot plate of stapes, oval window up to the brain cells or brain center. And mixed, whenever patient is having conductive deafness and sensory neural loss both, at that time mixed. Sometimes general practitioners get confused with what is mixed deafness, how it should be recognized. So there is one report and the audiogram is showing mixed deafness. How we can define this? So conductive deafness and sensory deafness, when both are present, at that time it is called as mixed deafness. For example, I am giving you one example. If a patient of 50 years old came to you and he is telling that I am having left side deafness. Okay. So what about right side? Right side it is some bit less, but on left side it is more. So if you do otoscopy, there is big perforation to the tympanic membrane. And if you do audiometry, at that time what you see, there is conductive deafness due to that perforation, number one, and sensory neural deafness due to his age problem. And that's why he is having opposite ear also little bit impaired. And another ear which is having complaint, there is perforation also, and there is neural transmission deficit also. That's why it is called as mixed deafness. So easily ENT surgeon gives comment कि अरे he is having conductive deafness, अरे he is having sensory, he is having mixed deafness. So whenever patient is having only perforation and no sensory neural problem, at that time it is conductive. If patient is having intact eardrum, all the things are clear, no wax, the external auditory canal is good, all the things are good, still patient is having deafness, and if we do the tuning fork test, we can get sensory neural deafness. So it is plain sensory neural. And whenever both are present, as I given an example, that is mixed type of deafness. So here we can see after the foot plate, there is conductive, and after foot plate, there is the problem, which is the perception, or which is neural problem or nerve problem or hair cell problem. At that time, patient is having SMUs. As we have seen when we learned in our graduation, at that time we have seen there is one basilar membrane, there is tectorial membrane in between, there are hair cells, the hair cells are having hairs, and whenever tectorial membrane rubs on the hairs, at that time due to external waves, sound produces and it goes to the brain center. The exact mechanism of carrying the waves from these hair cells to the brain is not yet known. But there are many school of thoughts, there are many theories, and which are claiming that this is correct. But it is the mechanism or neural transmission of the sound wave, converting from sound waves to the neural transmissions. So this is external ear, middle ear, and internal ear, and this figure is showing what are the causes of deafness. Okay, so external ear starting from atresia, wax, foreign body, then middle ear congenital otitis, congenital problem or congenital fusion of three bones, that is mediastinus stapes, then otosclerosis, traumatic injury, tumors, and the internal viral may be can cause problem, congenital Meniere's disease, then ototoxic drugs, head injury, then labyrinthine problems, then vascular problems, or sometimes it is idiopathic problem. So conductive deafness, many patients comes to your OPD with external ear and middle ear causes, that is just I have described. So sensory neural deafness, just I have described the causes, what are they. This thing is very important in जनरल प्रैक्टिस दैट पेशेंट कम्स दैट पेशेंट इज हैविंग सडन डेफनेस 2 दिन पहले अच्छा था अभी कल से ही अचानक हो सो व्हाट आर द कॉजेस सो यू हैव टू फाइंड in between these four causes sudden deafness one may be vascular patient may be having receiving drugs for some vascular disease that is coagulant or anticoagulant then traumatic patient is having history of trauma over the year. In ototoxicity, patient may be taking some drugs like ototoxic drugs like gentamicin or amikacin or streptomycin or something like that. So it can be ototoxicity and functional. Functional means sometimes, there are many patients in your OPD that they behave like that I'm not getting any hearing or I can't speak or something like that. So one trick I will suggest you when functional patient comes for sudden deafness. So all the parents are relatives are worried how he cannot get hearing or something like that. So at that time, you just keep them away. You ask them to sit outside and just take tuning fork and put it into the vertex of the patient and ask patient with sign language whether he can hear or not. So functional patient says yes in front of doctor, but in front of relative he says no, I don't get any hear. Just like that, when patient speak, पेशेंट का स्पीच लॉस सडनली होता है. अभी टॉपिक ये है निकला है तो इसलिए मैं बोलता हूँ स्पीच लॉस निकला है, स्पीच लॉस बता रहा है. Suddenly in the morning he is not speaking anything, everybody is shaking him and कुछ तो बोल, he is not speaking anything. This is functional. So what you just ask patient to put his tongue outside and ask the patient to say ah. Don't speak. So first tell patient don't speak anything. Only say ah. So if chord movement is normal, then there is no problem for the voice. So patient automatically starts speaking. So treatment of deafness, treat the cause, sudden deafness or SN deafness, specific treatment, vasodilators or vitamins. And one of the important thing is hearing aid. So many patients comes to you as a family physician to ask the recommendation of hearing aid. But one tip I want to give you that no patient is happy with hearing aid. ऐसा कौन सा भी patient नहीं है जो hearing aid से है. So there are many types of hearing aids. Body level है, जो जेब में रहता है. behind ear level है, into the canal है. Now, nowadays, there are two types of hearing aid. One is analog and another is computerized. It is called as digital. Okay. So in analog, we can't get direction of the sound, but in case of the computerized hearing aid, we can see or we can get the direction of the sound. It is hearing aid is nothing but amplification of the sound. It is having three components. One is mic, number two is amplifier, and number three is speaker. So externally, mic is there. In between, there is amplifier, and number three, that is speaker, which is inside the ear, that is near to the drum. That is the function of hearing aid. So whenever you are suggesting any hearing aid to the patient, first tell them that this is not the thing which is given by God. The God, nature has given you hearing up to this age, but henceforward you have to depend on hearing aid, which is only aid. That is not the permanent solution, or that will be not satisfied you. Purchasing those two, three sentences must tell family physician to the patient. Purchasing of hearing aid is a purchasing of some golden ornament, because the prices nowadays of hearing aid are coming to the around about 20,000 or something like that. So you have to use it properly. You have to maintain it properly. You have to show the audiologist properly, and then you can. So this is the thing in case of deafness. So otomycosis, one of the disease which comes to family physicians in rainy season, that is causes are moisture, then chronic fungal infection, infected wax, and diabetic patients can get more otomycosis. The symptoms: itching, pain, otorrhea, deafness, tinnitus, foreign sound in the ear is there. And the typical diagnostic, differential diagnostic sign is cotton-like growth inside the ear, or wet newspaper like mass in the ear. 100% it is otomycosis. It can be found in rainy season. We have to start antifungal drops, just like Candid, cotramazole, or junction violet paint. We can paint the ear. The junction violet is the best paint ever I have seen, and which is very old. We are using, means medical fraternity is using it since last 50 to 60 years. So if you do junction violet paint in the ear, there is all the fungal things which are in the ear, they can get absorbed or they can't grow on that. So junction violet is very good treatment for that. So cleaning of the ear, antifungal drops, cotramazole 1%, salicylic acid, and junction violet. Steroid drops are contraindicated in otomycosis. Never put steroid drops in otomycosis, because the growth of fungus is more with steroid drops, though it gives temporary relief, but afterwards it can recur once again. Then many patients of wax comes in the your OPD. It is normal secretion of ceruminous glands, sebaceous glands, and accumulation is there due to defective shape, secretion, variation of chemical composition, dusty occupation. So wax can produce symptoms like deafness, pain, itching, tinnitus, headache. One thing I want to uh, share with you, that wax is useful for body. Wax is very much useful for body. How it is useful for body? That's why God has created ceruminous glands in the body. Some people say अरे क्या वैक्स है, ऐसा है वैसा है, गंदा है. ठीक है, वैक्स हमें दिखने को और इसमें को तो बहुत बुरा लगता है, लेकिन वैक्स इज यूजफुल फॉर द बॉडी व्हेन इट इज इन द लिमिट. How it is useful? Number one, it doesn't give high waves of sound in the ear. It protects. Number two, सपोज भारत में अगर बॉम्ब फट गया तो वैक्स जो है वो उनको कम करता है वेव्स को, साउंड वेव्स को ऑटोमेटिकली. Number two, wax is sticky. So any insect tries to go inside, it can get accumulated or उसमें फंस जाता है. Any insect can't go inside. Number three, wax is having mild odor. उसको एक odor रहता है जिसकी वजह से इंसेक्ट्स वहां तक जाता है और वापस जाता है. तो आज तक ना आपने ऑब्जर्व किया होगा, इतने दिन से हमने देखा है कि अगर कोई सोता है तो रेयरली उसके कान में चींटी और कुछ तो भी जाता है. क्यों? क्योंकि वहाँ पे ओडर है. और वैक्स जो है अंदर ईयर के अंदर, वो ईयर को प्रोटेक्ट करता है कि एनी slap or some traumatic injury directly hit on the ear pinna. So at that time, wax takes care of eardrum, though it is 2 to 3 centimeters away from it. So these are the important things of wax. But when it is abnormal, when it is excessive, when it is discharging, when it is infected, at that time, the wax should be removed because it causes symptoms like deafness, pain, itching, tinnitus, foreign sound in the ear, and giddiness. That is the problems which are in case of wax. Treatment: wax softener, as all of you know, Solivax, Waxol, etc. There are many combinations. Those we can be used wax softener. So removal of wax, all of you must have Jobson-Hoff probe in your OPD to remove the wax. Jobson-Hoff's probe is specially meant for ear wax, which is smaller than Vectis. Vectis से भी छोटा होता है. आजकल सर्जिकल शॉप में easily available. So you have to take 4 to 5 Jobson-Hoff probes in your OPD. Whenever patient of removal of wax comes, at that time you can easily remove the wax with Jobson-Hoff probe. आगे की तरफ प्रोब रहता है और पीछे की तरफ कॉटन के लिए उसको सेरेशंस रहते हैं. And ear syringing, as you know, syringing can remove the wax. So these are some pictures of wax, so which can be removed. After removal of wax, patient can be very comfortable with ear. Then foreign bodies in ear, living or non-living, living insects, maggots, they can cause the itching in the ear. And non-living, hygroscopic and non-hygroscopic. Hygroscopic means seeds, watana, peas, all the chana, harbara, all these things are hygroscopic. They can swell after 2 days. But non-hygroscopic can be there, but they can't swell. Just like ball bearing, just like plastic, just like pencil. Pencil means wooden, so they can't get swollen. So this type of foreign bodies can be there. Then nasal common problems which we can see in the general practice, that is common cold, chronic rhinitis, atrophic rhinitis, and rhinosclerosis. So leprosy and fungal infection can also be there. So non-infective allergic and vasomotor rhinitis. So allergic rhinitis, reaction of nasal mucosa to allergens is called as allergic. There are many patients in your OPD. Doctor, I am having much sneezing, and after that I get rhinorrhea. So reaction of nasal mucosa to allergens is called as allergic rhinitis. And important symptoms are sneezing, rhinorrhea, irritation, and obstruction. The common allergens are inhalation, means atmospheric पोल्यूशन से जो होते हैं, कार्बन डाइऑक्साइड, कार्बन मोनोऑक्साइड, या जो ये निकलता है साइलेंसर से जो धुआं निकलता है, उसमें कार्बन मोनोऑक्साइड CO2 ज़्यादा, C2 ज़्यादा रहता है, तो इसके इनहेलेशन से ज़्यादा एलर्जी होती है. देन इंजेस्टेंट्स, दैट इज कॉन्टैक्ट और इंटेक, दैट इज कुछ खाया, पॉपलेट खाया, प्रॉन्स खाया, तो उससे एकदम एलर्जी आती है, रैशेस उठते हैं, रैशेस आते हैं और नेजल डिस्चार्ज शुरू होता है. देन नायलॉन or some type of cloth can be give the allergy, and patient can have the swelling over all over the body and itching with rashes. Then some drugs can have allergy. Then infections, some infective focus in the body can cause allergic rhinitis. Even caries tooth can cause allergic rhinitis because that infection is giving some proteins or discharging some proteins, and those proteins are not acceptable by body, and that's why patient gets allergic rhinitis. The endogenous allergens are helminthisis. Helminthisis can cause the allergic rhinitis also. So patients come to you in allergic rhinitis with sneezing. The difference between allergic rhinitis and chronic rhinitis is simple. The simple rhinitis or common cold is having 4 stages. That is, first patient gets rhinorrhea, then patient gets fever, then patient gets mileage, then patient gets upper respiratory tract infection, and then lower respiratory. It is due to all the type of viruses, adenovirus or the rhinovirus. But in case of allergy rhinitis, there is no virus causing this nasal discharge. It is due to allergy. There is antigen antibody reaction, and it secretes histamine, and that histamine causes sneezing, rhinorrhea, and irritation. So irritation, obstruction can be there in case of. Number 2 is common cold or simple rhinitis is not episodic, but rhinitis, allergic rhinitis, is episodic. Common cold takes 3 to 4 days to cure, but allergic rhinitis cures up to the evening. So there are many ladder of antihistaminics. Since last many days we are using antihistaminics, just like acetamizole, cetirizine, levocetirizine, many types of them, ibastinin, then montelukast. There are many, and companies are providing us with all types of combinations. So the best on and off for same patient. So many antihistaminics in front of your table in your OPD, but to choose a correct antihistaminic is very tough job. It is not very easy. So it is just like trial and error. Previously for allergic rhinitis, you heard that Merck Pharma has given the antigen trial on forearm, and that report have to send to Bombay and Delhi, and then we can get the drug. But it lags behind because there were no proper revision. According to my view or my logic, what I think is the place where they gives on forearm the trial for antigen, that skin and nasal mucosa are having much difference. So it may not be working with that. But now newer generation of antihistaminics, they work good for allergic rhinitis or antihistaminic action. So this topic is very important. Some another time we'll have discussion with this allergic rhinitis, which is annual and perennial. Then DNS, many patients, these patients we have to send to ENT consultant if deviation is there, but diagnosis should be proper with X-ray Waters view, X-ray PNS Waters view, and if there is septal deformation, the types of deviation are C-shape and S-shape. There may be spur means angulation. There may be thickening means roughness, and there may be dislocation. Dislocation means the septum is dislocated from bony frame of nose. So simple test in your OPD to determine the DNS, that you just put tongue depressor or spatula below the patient's nostrils, and ask patient to exhale. So when patient exhales, so at that time, the obstructed side or DNS side or what patient complains, that side doesn't give any vaporization on the spatula or tongue depressor. And another side is blowing fully. So this test can suggest you what is the severity of deviation, whether patient is referred to consultant or what, or patient is easy with antihistaminic drugs or decongestant drugs. So this simple test, you can come to the diagnosis of deviated nasal septum. So in deviated nasal septums, most of the deviations are at the anterior side. That is what where S is mentioned. S is septum. PPE is perpendicular plate of ethmoid. NB is nasal bones. ULC is upper lateral cartilage. LLC is lower lateral cartilage. V is vomor, that is bone, peppery bone, and M is maxilla. So this is the structure of, just I want to show you to get the idea okay, whether deviations are more. So where S is shown, that is septum, that is cartilage, that is called as quadrangular cartilage, and there more things are deviated things are there in S, means septum. 90% deviations are on anterior side. So deformity, blockage, headache, recurrent cold, these are the common things. Then treatment, SMR or septoplasty, we have to send the patient to ENT surgery. So first, at the starting of lecture, I have given you idea that only 10% of your OPD patients of ENT should refer to the consultant. So these are the some patients, those you can refer to the consultant, ENT consultant for SMR or septoplasty. Then epistaxis, bleeding from nose, so traumatic inflammatory neoplasty or raised arterial pressure, tension, raised venous pressure, then drugs, miscellaneous. These are the causes of epistaxis. Patient comes with very emergency manner that patient is having bleeding from the nose. You have to do very correct treatment for that because any epistaxis is emergency. Small drops, few drops from the nose up to the massive discharge from nose, anteriorly or posteriorly, epistaxis is very, very emergency procedure. You have to take care of that thing urgently. If 20 or 30 patients are waiting outside your OPD and one patient comes with epistaxis, and if your assistant tells you that there is patient of epistaxis, we have to take that patient first inside and judge the type of epistaxis, severity of epistaxis, whether it is anteriorly or posteriorly, and whether treat to here or whether to next place or upper place, whether you can add between or you can send it. So this is very important when we can't wait that patient for OPD and all those things. So we have to see that patient. As you know, routinely it is very important. So miscellaneous causes are there of epistaxis also. That is very common factor in India. Guna फुटणे असं मराठीत आपण म्हणतो ना गुन्हा फुटणे. So unknowingly sometimes there is bleeding from nose. So after very reading very different papers, so the conclusion is that when there is calcium deficiency at that time, the nasal bleeding is on and off. It is very common and it stops immediately after the pressure. The first treatment for management of epistaxis is ice cold pack. You have to put ice packs on the nose and pinching of the nose for bleeding time or clotting time. So up to the clotting time, you have to pinch the nose for 5 to 6 minutes by clock. By clock means you have to put the clock, you have to see the clock, because sometimes what happens, we remove it very early and it comes one side. So local treatment, cauterization, chemical cauterization with silver nitrate or electric cautery we can do, and anterior packing or posterior packing we can do. The systemic treatment, control the BP, anti-hypertensive drug should be given. Then replacement of blood in severe cases, where blood loss is more, and if it is not responding to anterior packing or posterior packing, then patient we have to shift to ICU and give blood transfusion. Then coagulants, antibiotics, and sedative for the patient because patient is very much frightened of that. Then sinusitis is common disease which comes in your OPD. The main symptom, the main cause is nasal infection, common cold, obstruction, viral, traumatic injury, bacterial, or obstructions. So patient comes in your OPD first with pain, sometimes discharge, blockage of the nose bilaterally or unilaterally. There is dry cough because of PND. PND is post nasal discharge. Edema is there, tenderness for the maxillary sinus, congestion, and purulent nasal discharge. So all sinuses are equally transmitted or equally put their discharge from ostia in same manner, and they are having such a power that all the collection which is in the sinuses, it throws via ostia. So you have to put fingers on the cheeks to see the maxillary sinus. You have to see on frontal sinus, and you have to see the tenderness. So nasal, sorry, nasal examination is also important. We can see there is trickling of the discharge from the ostia or opening of the sinus. So these are the sinus studies where we can get pan-sinusitis, means all sinuses are involved. Number one is maxillary sinus. The middle one is ethmoidal sinus. There are two groups, anterior ethmoidal and posterior ethmoidal, and frontal sinuses. And sphenoid sinus is on posterior side. Posterior side. The treatment of sinusitis is very simple. In OPD, you provide general antibiotic, decongestant, and analgesic, and local nasal drops, steam, and sometimes antral puncture to relieve. So here we can see patient is having frontal sinus, right frontal sinus collection, frontal sinus collection. Something is collected in the right frontal sinus. We can see the eye, which is protruding outside and lateralized because of that collection, or maybe that may be growth or something. So, so CT scan of this patient, that patient is having liquid collection in the frontal sinus, right frontal sinus. So that's why the eyeball is shifted laterally and other side eyeball is on same. So the collection shows the measurement of around about 10 to 15 cc, and which is in the ethmoidal sinus and frontal sinus in between. So this patient, the 18 number bore syringe was put in that collection to remove the collection after giving the anesthesia, and it was aspirated, and the collection was out, and the eye was in the center, or the lateralization of eye was very much corrected. So this was sent for histopathology. So this is the post-op endoscopic picture of that frontal sinus from where we have removed, and then we have widened the ostia. So nasofrontalis duct with the Lackesky's faucet, and we have done the cases with this patient, and we widened the ostia, and the patient was all right. So this was the thing. What are the problems of ENT in general practice? Hope this this was very big topic. So I have selected some of them. What are the problems of ear and nose, especially in the. So with this, I conclude my lecture, and I uh, hand over the mic to Dr. Rupa Agarwal and Sunil Bhujbal for if there are any questions or queries, I will be glad to answer those queries. I'm not able to hear you. Hello? Hello? Hello?
Hello.
Hello? Yes, sir. Now I can hear.
Hello. Sir. Okay. One question is, sir, post-COVID epistaxis comment. Just comment about post-COVID epistaxis.
Post-COVID. So nowadays, there are many cases which are coming or abruptly giving the things which are not certainly known for this thing. So many times when post-COVID patients are having epistaxis, at that time the packing is also very difficult in these cases. So some cases of post-COVID with antibiotics and with high antibiotics and with the coagulants which we can tackle with these things. And there are many cases with post-COVID, the post-COVID epistaxis. So this is very newer topic. So though we are having new to it, we have to use the traditional methods of the this thing, stopping the epistaxis. One thing I want to mention here, Abgel, which is called as gel foam, which is absorbable cotton, if it is soaked in botroclot, so that if that keeps in the nasal cavity, at that time this can be stopped and we can make control with that. But minimal discharge in epistaxis is found in post-COVID cases. Not every case, but some cases we can find, as it is respiratory tract disease, and nose is the first thing of respiratory, first organ of respiratory. Okay, then hello, hello. So should I start now? I can't hear Dr. Joshi, Dr. Bhujbal.
हॅलो
Hello, now I can hear.
आवाज येतोय
आता येतोय.
सर वन क्वेश्चन
हाँ,
कोलेस्ट्युमा all three bones are removed
in cholestoma.
in कोलेस्ट्युमा
हाँ,
how much
oh,
bones are removed
हाँ. So if we
how
take the
many
CT of mastoid region, at that time, if we are seeing that plates are intact, there is one plate, it is dural plate, and one plate is sinus plate. The dural plate is on upper side and lateral side there is sinus plate. So if patient is having eroding disease cholestoma, then we have to remove all the cholestoma. So cholestoma is having characteristic to eat the bones. In simple language, I am telling you, to eat the bones. It is already have done all the destructions in the mastoid and it has spread. And it is onion like structure, onion shells like structure, and it eats the bone. So there is sometimes we have to remove the ossicles. Ossicles means malleus incus stapes, and sometimes we can keep it. So there are three types of mastoidectomies. One is cortical, one is radical, and third is modified radical. In case of cortical mastoid, only cortex of the mastoid bone we have to remove. In case of radical mastoidectomy, we have to remove all three bones, malleus incus stapes, with mastoid region or mastoid cleaning in the mastoid cavity. And number three is modified radical. We have to keep the bones, three bones, malleus incus stapes, which can give hearing, good hearing, and we have to remove the mastoidal cholestoma or mastoidal disease with the help of burr or drilling burr. So it depends on the disease, how much it is expanded and how much it is extended. Okay.
okay sir next question can a
Yes.
doctor use hearing aid
Uh,
by using stethoscope
using
if needed
hello
stethoscope
stethoscope.
हॅलो
हाँ
वापरताना हेअरिंग एड
हाँ
वापरू शकतो का डॉक्टर
हाँ. Doctor can use hearing aid, but the fineness of the heart sound he will not get. Fineness of the heart sound.
ओके
Okay,
सर
so it is
ओके
transmitted
सर
from the hearing aid to the inner side. So I will advise the intracanal hearing aid for such doctors, those who are having hearing deformity mild with if he want to use stethoscope. So stethoscope, the rubber part of the stethoscope can easily fit on the hearing aid and patient can get very much good sound. So the other behind ear or body level, they are not useful in that thing. Intracanal is the useful for doctors. Okay.
Okay. Another one question, sir.
Yes.
In otorrhea, can we advise ear drops?
Yes, we can advise ear drops, but we have to see there is no perforation of tympanic membrane. So what is the procedure? First, what we'll do, we'll clean the ear with cotton. We'll do otoscopy. There is no perforation. Then we can put the drops. If we put drops without doing otoscopy, those drops will go land in the middle ear and the external infection will go in the middle ear. So that's why in my lecture, I suggested that please keep otoscope in your OPD, that after cleaning the ear, we can see the drum. And if patient is having perforation and still we want to put drop, at that time, only steroid combination drops can be helpful if there is no inflammation. So while putting drop in case of otorrhea, very, very precautious about putting the drops. Okay?
ओके सर माझा एक प्रश्न आहे.
Yes.
जेव्हा डेक्रोसिस्टायटिस होतो पेशंटमध्ये,
Yes.
तेव्हा एंडोनेझल DCR
बरोबर.
वर्सेस ओपन मध्ये केलेलं एक्सटर्नल DCR,
बरोबर.
त्याच्यामधले रिझल्ट वाईज चांगले कोणते राहतात ओल्ड एज मध्ये मेनली?
ओल्ड एज मध्ये आपल्याला आपण जेव्हा DCR करतो तेव्हा एंडोनेझली म्हणजे ट्रान्सनेझली जे आपण DCR करतो, दोज आर व्हेरी मच हेल्पफुल. There are 2-3 things or 2-3 benefits by doing via nose. That one is scar is avoided and the sac is bypassed. So canaliculi are intact or patent, and if we do sac syringing and the water is coming out from the another canalicula, that is the test for endoscopic DCR. So that is very much helpful for the patient. So we do many times endoscopic DCR and sometimes it gets failure. But that failure rate is because of only of due to fibrosis, not opening widely. If we open it widely open, then we will get good results. And another thing I want to suggest that after every 6 months, we have to do the endoscopy of endonasal DC. The external DCR, it can give scar and we have to use bone punch and all those things. So that is bit tedious job, but endonasally it is very easy. So every ophthalmologist from this thing Shalakya department also do this procedure as far as my view is concerned. All people should do this thing. Okay? Means ophthalmologist.
Sir, another question.
Huh?
In allergic rhinitis, patient have to take antihistaminics
Yes.
all their life.
Okay.
Or is there any alternative for it?
For allergic rhinitis?
Antihistaminics.
Antihistaminics. Yeah. Okay. So one quote is there in the book, that is Scott Brown book. Everything under sun is allergy. Everything under sun is allergy. So there are many things and many persons those are having susceptible for different types of allergy. So number one, they have suggested in Scott Brown that you have to recognize that allergy, what type of allergy you are having, number one. And number two is you have to avoid that thing. Or if you are having dust allergy, don't go in dusty. If you are having old paper allergy, don't put hands in your old paper. If you are having oil allergy of some mohri or something like that, so you have to avoid this. If you are having fish allergy, you have to. I have seen the patient who is having limca allergy. So the avoid the thing is the first treatment. Number two is nasal lavage or nasal douche, or in Ayurveda which is called as Jalaneti. It is very much important in case of allergic rhinitis. How it is useful logically? If we put logic in behind this procedure Jalaneti, the mucosal flora which is having ciliated columnar epithelial cell and the antigens are trapped in the cilia and they try to secrete histamine after antigen antibody reaction. So what body will do? Body will try to put all this histamine through his nose outside the in the atmosphere. So what's body's first reaction? Body's first reaction is sneezing. What is body's second reaction? Body's second reaction is edema to fight the antigen and histamine. What is body's third reaction? Body discharges fluid and it tries to expel it out. So instead of that thing, if you do morning and evening refreshment of nasal flora, nasal mucosa, columnar ciliated epithelial cells, then patient may get good results. So my suggestion or my experience till up to today, what suggests if you tell the patient to do Jalaneti, patient will 100% tell you after 1 month that doctor, my dose is now reduced. So previously I used to take 2 tablets. Now I take 1 tablet twice a day or something like that. So this is the one of these. So conclusion is number one, try to avoid antigen, and number two is Jalaneti, and number three is antihistamine. This is the mature or ideal treatment for allergic rhinitis. Okay.
Uh, okay. Sir, what is impedance audiometry?
Impedance. Impedance audiometry.
Yeah.
Impedance audiometry is
Oh,
done in case of the patients, those who are having impaired hearing with diffuse symptoms, or patient is shows his routine audiometry in different things. At that time, we use to take the pressure of middle ear, and with that pressure gauge, we have to calculate impedance audiometry. So whenever we do simple audiometry, at that time we rely on patient's answers. Whether you can get hearing, yes. Whether you can get hearing, no. Whether you can get hearing, yes. So patient's answer we rely on routine audiometry. But in impedance, with the machine, we can evaluate the internal pressure and the brain signals. We can get the idea and we can get direct report in our. Suppose one patient who is not giving proper answers and his two consecutive audiometries are different. At that time, ask that patient for impedance. If patient is having otosclerosis, at that time, ask the patient to go for fixation of foot. If the patient is having sclerosis or sclerotizing disease and patient is not giving any sign of hearing with profound conductive loss, at that time we have to tell the patient go for impedance. So this is the main difference between routine audiometry and impedance audiometry. So nowadays the machines are so easier that after every third or fourth patient we advise to get done impedance audiometry. So impedance audiometry is having very much good value for this. And next to that is BERA, that is brain evoked study of. Okay.
okay. Sir, Dr. Sriram Rishu want to ask one question.
Yes. Yes, sir.
हॅलो हॅलो
हा.
सर नमस्कार.
नमस्कार सर.
ते मगाशी सांगितलं तुम्ही फ्रंटल सायनस ड्रेन आउट करताना लोकल ब्लॉक द्यायची काही जरूर असते का स्प्रे करायचं काय आहे?
So in that thing, when we come to pre-operative, at that time first we have to give sedation and injection atropine intramuscular, number one. Number two, we have to keep 4% ribbon gauze in the nostrils. Both nostrils we have to put 4% liquid lignocaine, and after 10 minutes we have to give 2% xylocaine. As this patient was hypertensive and old age, we used plain this thing xylocaine without adrenaline, and we did the procedure.
Okay.
But anesthesia, local anesthesia is very important in this case.
Yes sir.
Okay.
Thank you sir. धन्यवाद सर.
Thank you.
Okay sir.
हॅलो.
Hello.
सर छान लेक्चर झालं आणि डॉक्टरांचे जे क्वेश्चन्स होते त्यांचे पण छान आन्सर्स मिळाले आणि आमच्या शंकांचं बऱ्यापैकी निरसन झालेलं आहे. इन फ्युचर वी विल ऑल्सो रिक्वायर्ड युअर guidance, and we
surely.
we will surely with us for that. I hand over charge to Dr. Sriram Joshi sir for further.
Yes, I want to speak a few words for that team.
Hello.
Yes.
Yeah, hello. I, Dr. Sriram Joshi, Secretary GPA Pune, extremely thankful to today's speaker, Dr. Pramod Diwan Sarji. He given us a very good, knowledgeable lecture, which is very useful to our day-to-day practice. I also thank to today's convener and our Joint Secretary, Dr. Sunil Bhujbal sir. I also grateful to all doctors who attend this lecture. I also thankful to our technical partner, DigiShield. Thank you all. Thanks. Hello. Hello. संपला नाही ते झालं ना.
Hello. 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 Hello.
Hello.
Hello. I want to speak a few words for all the dignitaries.
Yes, sure, sir. Please.
I'm very much thankful to Dr. Sunil Bhujbal, who is my colleague in Bharati Vidyapit, and for arranging or convening this nice webinar. Dr. Scientific Session Chairman, Dr. Praveen Darak, and Dr. Prakash Mahajan for inviting me. Dr. GPA President, Dr. Rupa Agarwal, for giving me this opportunity. And finally, Dr. Sriram Joshi, my friend since last many years and a good general practitioners. Many procedures I have done in his OPD setup previously when I was in Pune. So now I am also in Pune, but when I was student, I have done many cases in his OPD setup. So I am thankful to all, and thanks for calling me for this session. I will be very glad if you ask me some another time to give me specific topic, and I will come forward. No problem. Okay.
Thank
Thank
you.
Great, sir.
Thank you, sir.
It is
Thank you
really
very much.
nice to have you, sir. म्हणजे छान टीचर असले की आपोआपच स्टुडंट्सचा विषयाबद्दलचं नॉलेज किंवा इंटरेस्ट वाढतो, तशा प्रकारचं फिलिंग आहे. सो रिअली थँक्स फॉर बीइंग हिअर फॉर दिस वंडरफुल एक्सप्लेनेशन ऑफ दिस टॉपिक, सर. थँक यू अगेन.
Thank you. Thank you very much. Thank you, Shri Ram. Thank you.